Everybody to this evening. This is Solve Talks presented at Google, and I want to especially thank you for hardy souls coming out tonight. I'm really excited about tonight and this conversation. You might remember 6 years ago, there was a very intense summer, the summer of 2009, where there was a lot of talk about death panels. And there'd be town meetings, right? Remember congressmen would go to town meetings and people would talk about, are there going to be death panels? And people were very concerned about it. And some people said, well, that's nonsense. Well, now the Affordable Care Act, aka Obamacare, is very much sort of integrated into the healthcare system. And yet, there is still, whether you like Obamacare, whether you don't, there's still a lot of work to be done. A lot, just as a patient, and I know some of you are doctors here tonight, there's a lot to be done in that sort of patient-doctor relationship, improving the patient experience. So we've got a great panel tonight to talk about that and then to answer your questions. I'm going to start here. Rushika Ferdandopulle is the CEO of Iora Health. He's also on the faculty at Harvard Med School and is on the staff at Mass General. Heidi Williams is an economist at MIT. She just, in the last few weeks, won the MacArthur Genius Grant, so you can expect to hear a lot of really smart things tonight. And Denny Ausiello is the chairman emeritus of Mass General Hospital. He also is a professor at Harvard Med School and does many other things, which may come up this evening. But Heidi, I'm going to direct the first question to you. About 18% of our GDP is given over to healthcare in America. And that's a number that's gone up steadily through the decades. I wonder, why has it gone up so much, and is it a problem that so much of our national focus and money is eaten up by healthcare?
Yeah, so that's definitely an active area of debate. The share of GDP that we as a country choose to devote to healthcare is high and increasing, and that's also true in other countries. So it's definitely a global phenomenon. So when you ask, why is something happening, it's not that you should think, well, in the US we're doing something different. That trend extends to other countries as well. It's been interesting to see the way that economists have looked at that to sort of say just what's going on from a factual perspective. And so, people have looked at, is it that the population is getting older and that older people spend more money, or is it that people with insurance spend more and maybe more people are insured now than there were in the 1960s? Those factors can explain some part of it, but what economists have sort of decided is that most of the growth in healthcare spending is explained by technological change, and that can happen in a lot of different ways. But one thing that a lot of people have in mind is that the way that we treat patients now is better than the treatment that they were getting in 1960. So work by economist David Cutler at Harvard has done a lot to look at some specific case studies of if you're a low birth weight infant and you were born in the 1960s versus today, you're much better off, but we're also spending much more money. And that money looks like it's saving lives, but those trends move together. Similarly, if you have a heart attack now versus a heart attack in 1960, you're doing much better in terms of your outcomes, but that's come at some cost. And so oftentimes people talk about healthcare cost growth in isolation, but I think a lot of the discussion is better had on what's been the change in the value of spending that we're getting, and is the quality adjusted healthcare that we're getting improving, and trying to focus on that kind of metric as opposed to just costs in isolation.
So Denny, I think that's such an interesting point, because technology generally gets cheaper, right? And like DVD players came out and they were expensive, and now they're not. And computers originally were really, really expensive, and now you can get like a really cheap laptop. But that doesn't seem to happen with healthcare, technology and healthcare.
Yeah, the argument is that everything that we invent in medicine only raises the cost.
Right.
I've debated Zeke Emanuel and others on this. Perhaps vaccination may be the one that, that changes that metric. But it's not the technology per se, it's how it's used. 25 to 30% of our Medicare budget is spent in the last year of life. We often use technology in a way that doesn't provide either realistic or even outcomes-related manifestations of that technology. And I think one of the issues that Heidi raised is that there are choices to be made at the level holistically of a government or a society as to how much of your GDP you want to spend. But the expectation is that there's a reward for that increase. Much of the dialogue over the last 10 or 15 years has been, despite the fact that our percent of GDP is the highest in the world, the quality of our care delivered by many metrics is nowhere near the highest in the world. Now, we can debate those measurements, we can debate whether that's true in Boston versus some other site, but realistically, there is a much more heterogeneous aspect to the way we deliver healthcare in the United States, and therefore not uniform in terms of those statistics. The other point that you raise is that despite the fact that we have a very complicated healthcare delivery system, and I'm sure Dr. Ferdandopulle will tell you about, from a patient-centric point of view, why some of these things have to change dramatically. There is an enormous over-debate in my mind that we focus on drug costs. Now, drug costs of the total healthcare bill, even in the largest critic of the pharmaceutical industry, are no greater than 15%. And 85% of that number are already generics. Yet the reason that there's so much attention is that if you want to focus on the other 85%, then you got to focus on doctors and hospitals. Or the other major reason is that 45% of out-of-pocket costs come for drugs. So that, unfortunately, the technology you described, if someone comes to my office or Dr. Fernandopoulos' office and wants an MRI for their tennis elbow, they don't even know the cost of that MRI, and quite frankly, the doctor probably doesn't either.
I want to get into a bunch of stuff that you said, but in terms of drug companies, you do some work with drug companies.
Absolutely.
Right?
I'm a lead director on the board of directors of Pfizer. I've been there for 10 years. I also sit on many biotech companies here within a few hundred yards here. I believe that drug discovery is ultimately absolutely essential to raising the quantity and quality of healthcare. I'm not a total apologist for pharmaceutical practices or pharmaceutical pricing. I'm more interested in discovery. How do we make the best drugs possible? Let the marketplace dictate how we spend on it. But I do think that while we can focus on the price of drugs, we have to understand that there's a lot more to the healthcare system that needs to be fixed than simply the cost and quantity of pharmaceuticals.
So, Rushika, to pick up on something that Denny was saying, if we're spending an awful lot of money, then why isn't our healthcare at the very best in the world?
So it's not clear we're spending our money smartly or well. I think if you look at almost every sort of estimate of what we're spending money on in healthcare, we think that at least 30, and maybe some would argue 50% of what we're spending on is waste. And let me be clear what waste is. Waste is not only things that are provided to people that have no benefit, they're things that are provided to people that actually cause harm, right? And I think it's that we are doing things to people that, like not only are no benefit but cause harm. Why?
Give me a couple examples there.
Yeah, no, so I think if you look at probably the best way to look at it is the variation data. So some friends of ours, up at Dartmouth who've done a thing called the Dartmouth Atlas, and they look at the utilization rates of various procedures. They vary, if you look at geographic area to geographic area, as much as 1 to 7. 7 times as much, and without any difference in outcomes. Right, which tells you that 6 times the people in the high utilization area, places like Miami or South Texas, or places that traditionally have been high utilization, are getting procedures that actually don't cause benefit. Now, why is that? I think there's some very deep-seated reasons, but one of them, I think, really is the payment model, how we end up paying for medical care. We, by and large, in this country, pay for care fee-for-service per service, and then we hide the cost of that from the people making the decisions, both the doctor and the patient. And so it's probably not surprising that we get this sort of behavior.
So, Heidi, a few things have been mentioned in terms of like where our money is going out the window potentially. From the research you've done and the research that colleagues have done, does last year of life, which Denny mentioned, does the idea of just giving people unneeded procedures, did those resonate with you as like, yes, we need to talk about those issues more, that we are wasting money?
Yeah, so as an economist that primarily looks at the data and tries to do empirical research, I feel like we're sort of missing a lot of the facts that we need in order to have a really concrete discussion about some of these things. So just to take one example, so the Dartmouth Atlas. So the Dartmouth Atlas basically documents that patients in Miami get a lot more medical care than patients in Minneapolis. And so that's often interpreted as Miami is overspending and Minneapolis is sort of spending an appropriate amount. And so in some research that I've done with my colleague Amy Finkelstein here at MIT and Matt Jensko, who's at Stanford, we tried to investigate what's actually the source of that underlying variation. And the main idea of what we did is very easy. We looked at, in the Medicare claims, some people move from Miami to Minneapolis, and some people move from Minneapolis to Miami. And if all of that spending variation was about differences in places where doctors in Miami just practice more intensively, then what should happen is when someone moves from low-spending Minneapolis to high-spending Miami, their cost should increase. And similarly, when someone moves from high-spending Minneapolis to high-spending Miami to low-spending Minneapolis, their cost should decrease. And so in the data, what we see is about a 50-50 split. So it looks like your spending does adjust when you move, but a lot of what determines the spending variation across places looks like it's determined by patients rather than by doctors. And so the rough decomposition we do suggests that's about half-half. So about half of the geographic variation is explained by place-specific factors or doctors, and about half of it is differences in patients, which could include patients in Miami are just sicker, and so they demand more care, or they have more of a preference for getting higher levels of utilization than people in Minneapolis. I know my parents live in the Midwest, and they just don't go to the doctor that often, and some other places of the country, like people are more interested in going to see their physicians and getting more procedures. And so that kind of decomposition, I think, is really useful just as a set of facts to say, how should we interpret this geographic variation? Is that efficient or inefficient? And our work is really just starting to provide some of the facts into that discussion. And I think there's just a lot more to learn about, how can we think about variation on the supply side versus on the patient side, and what does that tell us about whether this is a wasteful spending or not?
There was some pretty recent research. I think you mentioned David Cutler before, and I know he was involved in this. And it was identifying these people. I don't know how widespread you think this is, called cowboy doctors, which is like a great name, if you can imagine a cowboy doctor. But it's these doctors, and he said they tend to be, I think, a little more in private practice than as part of large groups of people. But they will often do things, at least according to the research, maybe at the end of life, where it's very unlikely the person is going to get well again, but they do a whole bunch of procedures to try to help the person out, and it doesn't end up really helping them that much. Do you think like those sort of one-off, I'm interested in what the doctors think too, but Heidi, do you think these sort of individual people making decisions that are maybe not supported by evidence, that's like a huge problem?
Yeah, so the work that Kara's talking about was a survey that was done, which basically asked cardiologists, here's a case which is sort of a gray area, and do you think that you would treat this person intensively, or do you think that you would treat them not very intensively? And so that variation in those survey responses is very correlated with these Dartmouth Atlas measures. It turns out it's also very correlated with the measures that I constructed in the study that I mentioned with these co-authors of mine, where if we look at, not just which places spend a lot, but which places look like they're the determinant of high spending, as opposed to it's just high spending patients in your area, our measures of these high spending places also correlate with those survey measures. And so I do think it's interesting that they seem to be picking something up that's a real characteristic of variation across places in the way that physicians practice medicine that does seem to have some empirical basis.
Denny, have you encountered, are there cowboy doctors at MGH?
I won't comment on the concept of cowboy doctors. I think what you're hearing is that these are nonlinear problems and that they are multifaceted. I will come back to the point that Rushika made, is that you cannot escape, however, the fact that we have a fee-for-service, procedure-based orientation to medical care that has largely existed post-World War II in this country, and we lead the world in that category. Now, my experience, and I've had the privilege of working at Mass General Hospital since I've been 17 years old, when I was a freshman in college and I first went work there. I'm very proud of that institution, and I quite frankly believe all of Massachusetts should be. But having said that, the monetary payments that are required at the procedural level innately drive procedures. I mean, that is just a fact of life.
So like if a physician says this patient should get an MRI, they get like a cut Is that?
No,
I mean,
that-
if you,
that-
explain how the fee-for-service works.
Well, if you're a cardiac patient, let's
Okay.
just take a very common disease. You come into the Mass General Hospital and are admitted to the Mass General Hospital usually with a whole host of illnesses, okay? And that's the other thing we haven't even begun to talk about, is medicine is not a disease, it's a series of comorbidities. And many of the confounding issues that were alluded to here, whether they're sicker in Miami or Minneapolis, et cetera, have a lot to do with the dialogue that occurs across those comorbidities. Not just the patient's intrinsic understanding of that, but the patient and the physician's dialogue around, should my heart disease and diabetes and asthma, et cetera, also be treated. But if you have, let's just focus on a cardiac disease state. The patients come in and they're often subjected appropriately to a significant number of diagnostic tests. Each of those tests is often done by a different specialty. Could be cardiology, could be radiology, could be surgery, et cetera. And each of those procedures is costed out and resourced independently within the institution and ultimately to the insurer and the payer. Most efforts in the last decade, including Obamacare, but over the last 25 years, have been to move to a much more capitated or bundled payment system. And certainly we are moving that direction, and I'm sure Heidi can give you much more elegant economic descriptions of this peripatetic journey that we've been on. But the rest of the world starts with that premise.
Okay.
And one, they pay a lot less for drugs, and I'm happy to tell you why, but let's just go on that assumption for the moment. And secondly, the quality measurements, at least that we currently have, show they do just as well, which is why I keep coming back there. I don't think the American public would care spending 18% versus 11% in France or Norway or Denmark, et cetera, if we could say our care was twice as good, our outcomes were twice as good. But for most of the metrics that we measure, that is not the manifestation of that delta.
Right.
So therefore, the obvious conclusion is we could spend half that amount and have the same results.
Yeah.
And when you're stuck with that, then you begin to point fingers. Where's the problem? Is it the payment system? Is it cowboy doctors, if that's what you want to talk about? Or I would even argue cowboy hospitals, because hospitals are driving volume revenues that actually are the margins for these doctors to be able to make money, even if they're salaried, et cetera.
Fee-for-service, cowboy hospitals.
So, can I tell a story?
Yeah.
So let me tell a story about a patient. I saw a patient in a practice here in Boston, and he was a filmmaker in his 50s. He said, "Doc, I have a mom. She's in her 70s. She lives in New Jersey. I had a practice where we were trying to build a new model of care where we would actually work with patients and, we were sort of paid a fixed amount as opposed to fee-for-service. He said, will you help me take care of my mom and come to practice?" I was like, sure. Let me meet her. And so I met her, and she was a healthy 70-something-year-old lady, played bridge independently, drove herself around, little diabetes, little hypertension. Great, met her. 3 months later, I got a call from this gentleman. "Doc, my mom is about to get a pacemaker. Can you figure out what's going on?" I'm like, "Absolutely." She seemed fine when I saw her. So here's the story. She had gone to the bathroom one day and looked in the toilet bowl, and there was a little bit of red. So like a good doobie, she went to a primary care doctor. "Doc, I noticed some red in my toilet bowl." Right? So, by the way, all of you, what's the most common cause of red in the toilet bowl? Beet urea. Someone said it, right. Eating beets probably, or maybe a UTI, maybe. But anyway, she went to the primary care doctor. Primary care doctor did what you're not supposed to do with the primary care doctor. He didn't work it up, didn't ask any questions, said, "That could be cancer. You should go see a urologist." Right? So she goes to the urologist's office. Urologist says, "This could be cancer. You're hammered where it looks like a nail. I have to do a cystoscopy, put a little tube in your bladder, look at your bladder. But because you're 70-something, before I put it under anesthesia, you should go to see a cardiologist to clear your heart." Denny probably recognizes this story. So this is a vortex of U.S. healthcare, right? You're like sucked in. By the way, what happened to the red in the urine? It went away the next day, right? This is a fishing expedition. It goes to the cardiologist. Cardiologist, nurse, said the review of systems. Nurse, I know, Mrs. Do you ever feel weak or dizzy? She's 78 years old. "Sometimes I feel a little weak and dizzy, Sonny. Put a Holter monitor on her to monitor her heart rate." So slaps a Holter monitor on her. She goes home. A week later, she comes back. They look at the tracing. Her heart rate goes slow at night, called asymptomatic bradycardia at night. The cardiologist says, "Nurse, this is dangerous. Schedule her for a pacemaker." Right? So point one is this whole thing is a wild goose chase. This was probably beat Iora and what didn't need to be worked up at all. Number two is a pacemaker a class 1 indication for a pacemaker? Pick up a phone, call a friend at Mass General. He's like, absolutely not. The risk of sticking a big trocar in this lady's groin, threading a piece of wire and putting hardware under her skin is far higher than this theoretical risk. Point 3 is if you look at her medication list for hypertension, she's on a beta blocker that slows your heart rate down. So I called the cardiologist. I said, we work with the family. With all due respect, we decline your pacer. Next time you should check the med list before you schedule a procedure. And so the gentleman said, doc, explain to me what happened. Does that urologist make money off of the cystoscopy? And the answer is yes, he does. Not saying why he does it, but he does. Does that cardiologist make money off of the pacer or the Holter? Yes, he does. That's how he gets paid. He said, what I love about you is you don't have a dog in this race. You work for me. I think we have a fundamental conflict of interest here, that people recommending these sorts of procedures are making money, and there's a huge information asymmetry. This poor lady had no way of pushing back. I can push back because I'm a doc. There's no way she could pick back. No way her son could push back. Are these people greedy? Are they idiots? Are they crooks? Well, there are idiots and crooks, but I think most of it is just we've created this culture where the payment goes one direction. You don't want to be sued. You want to make friends. Why did this primary care doctor refer to the urologist? Because then the urologist refers all his patients to the primary care doctor, right? So we've just set up a system where I think the wrong thing is happening to patients.
There's been some talk about other countries. Is there another country that has this figured out, where this woman would have gone in and somebody been like, whatever they should have said to her, well, let's see if this is sustained over a period of 3 days, or something that was much lower tech before we got into these implant situations.
So most other countries, and if you ask, so most other countries have a much more what I'd call strong primary care system, where people, primary care doctors feel like they manage things more. So very simple fact, in the US we have twice as many specialists as primary care doctors. In almost every other country that's reversed. There is a lot of data, I think, that there's a bunch of supply-driven demand, right? So if you have more of a blank sort of doctor, guess what? They fill their schedules. The stuff is all gray, right? And there's a tendency to actually do more. And even if you don't put perverse sort of stuff outside of it, when should someone come back? What's your threshold to admit? If there are empty hospital beds, if you have empty space in the schedule, that's what you do. I think in most other countries, they sort of, the system is sort of geared around it. And part of it's cultural, too. I think part of it's sort of cultural. And the patients are in cahoots with this, by the way, right? So I think I'm not surprised at all by your findings, that we've sort of conditioned patients to think more tests are better, more procedures are better, that doctor's doing the right thing for me. And so I think it's a very deep cultural thing among both docs and patients here in the US.
So, Denny, let me get to you. Heidi, I want everybody to weigh in this idea of other countries. Is there a model out there? It can be in this country. It can be like the city of Tacoma, Washington, totally has it figured out, or whatever. But is there some model that's better? Are other countries doing it better? I mean, I know you've written a paper about why our infant mortality in the US is higher than in some other countries. Why? And are there countries that have figured this out?
Right. So not to continue to be the negative person saying we don't know what's going on, but so I think the conventional wisdom is that we spend more and we don't get better outcomes, and that's often based on data that's not really obviously consistently measured across countries. And so the paper that Kara mentioned, we tried to collect natality records for births in the US and a few European countries that we could get similar microdata for, and to try to ask why we see that US infants seem to die at a much higher rate than their counterparts in Europe. And so people are probably familiar with those statistics. They come out about once a year. They say the US is ranked 20th on infant mortality relative to other countries in the world. And so in some joint work I have with Alice Chen at USC and Emily Oster, who's at Brown, we tried to just understand why that's the case. So it turns out one problem that you get when you get just tabulated data from the World Health Organization is that what's classified as a birth is not consistent across countries. And so in the US, we tend to classify very, very at-risk infants who have a very low chance of survival long after birth as births. But in some other countries, those would be classified as fetal deaths. And so when you want to compare health outcomes across countries, you need to make sure that we're sort of counting things in an equivalent way. It turns out that does matter, but it definitely doesn't explain why the US has higher infant mortality than other countries, although it does inflate the US reported infant mortality compared to Europe. what we basically found in our study is that during the first 30 days of life, which is what you can roughly think of as when infants have a lot of contact with the hospital system, the US actually has much better mortality outcomes than their counterparts in Europe. And that's true either in general, or if you look at infants that have the same birth weight and are sort of born at the same gestational age, we're doing much better. Where we fall behind is in months 1 to 12. This is a time period when these infants are generally not in the hospital, they're at home. And if you look just at the cause of death data, these are generally causes of death. The share of the sort of excess deaths that you see tend to be things like accidents and other causes that don't look very closely related to the medical system. And so that study really did a lot for me in just sort of thinking about, first of all, how do we measure and sort of make statements about cross-country comparisons of health outcomes? And I think just getting good data and measuring things in a symmetric way is really important. The second is, I think our work sort of roughly suggests a more nuanced picture that the US does spend more on saving these at-risk newborns, and that looks like it's reflected in the aggregate in getting better outcomes during the first month of life. And so that sort of speaks against this, general sentiment that we're spending more and not getting more. At least the aggregate data looks more consistent with maybe we are getting a return to our spending. And then the third thing is that there looks like there's an important component, at least for infant health, of sort of things other than the interaction with the medical care system that might have a lot of explanatory power about why we're getting worse outcomes. And so that's obviously just one case study, and we're really just looking at data from a few countries in Europe, and we can't generalize and all these things. But that really did a lot to shape what I thought sort of the questions were that we might want to think about across countries.
You both wanted to get in on this. Denny, you want to go first, and then Rushika?
Well, let me try to make a few general comments. I have had the privilege of being an attending physician and sitting on the Cambridge University board, a variety of other places. And I do think that the point that was alluded to earlier by Rushika is that there is a cultural issue here that I call the acceptance of more benign neglect in the delivery of what we call healthcare in this country across the world. And you heard the examples here in extreme, but a patient like that in England might not have even gone to a doctor. So if you start by absence, obviously less is done.
But that's just a cultural thing, right? That we're just culturally more inclined
So what I'm saying is that there is that culture.
Yeah,
that
okay,
I've seen it.
For sure.
I've been around for 40 or 50 years as a practicing physician. So then the question is there a component of benign neglect that is a function of you do worse because we have so much information that would benefit you, or you do the same? Now, we can debate each category. I don't know too much about infant mortality, but I know a lot about kidney disease and heart disease and diabetes. And I would argue that 50% of what we do or less is actually based on strong evidence. Most of medicine is still experiential. And I'm very proud of our physicians. I want to make it very clear. And I really think we need to strike the concept of cowboy doctors, cowboy hospitals, or whatever, because that implies both an immaturity and a lack of essence to the quality and quantity of what they do. But it is true that medicine is complicated, and I think where we really need to begin to make assessments is what is the information gap that we are currently living in that will allow us to do everything on the basis of 100% evidence-based. I remember giving this talk, actually it was here at MIT, and it was to a group of scientists, and I said 50% of medicine at the moment is practice is evidence-based. And somebody looked at me and says, well, what's the alternative? I mean, what does that mean? I'm a scientist. Everything's supposed to be evidence-based. Well, the reality is that medicine is practiced in a very episodic, symptomatic approach. It's been that way for 500 years. We take a narrow snapshot of the patient. We do the best we can with that information. We then send them out into a black hole where life occurs. And it is during that period of time where no other industry in the world would base decisions on the absence of that kind of information. And I often, when I give this lecture around the world, I often say I flew here in an airplane. And when I walked into the cockpit, I looked in and there's 100 lights on that monitor the internal and external environment of this airplane. When I go home tonight and I take the same flight home, the lights are all off and I ask why, and the airline captain says, I only turn them on every 6 or 8 weeks. Well, the reality is the way we interrogate our patients and ultimately the quality and quantity of information we get from them is quite random and episodic, and therefore doesn't allow for the building of the quality of information that is necessary to make the precision changes that we want. Therefore, physicians base their approaches much more on their personal experience than on the nature of the evidence that's available.
For anybody who goes to the doctor, ever plans on going to the doctor, the fact that 50% of what you hear is evidence-based is kind of scary. How do you get from 50% to like 80%, let's say?
The quality of that kind of information has to be garnered under more pre-symptomatic, continuous ways. We're living in a digital world today, okay? You're seeing the revolution of the monitoring systems, all right? Not just putting a Holter monitor on individuals, but understanding the readout of the human condition. We live in a generation where the human organism, for the first time in history, is actually the main repository of the scientific information necessary for us to make these decisions. It's not just at the level of genetics, although we've made an enormous stride there, but it's in the level of what we call phenotype, which is the sum of genetics, behavior, and environment. And we need a much more holistic assessment and toolkits and skill sets to assess that aspect so that we can now make much more definitive assessment tools about here's the diabetic, here's what we need to do, not when they come to the hospital. Remember, medicine that we call medicine occurs in a hospital is only 1% of all of health. The rest of the world and the rest of your day is spent someplace else. We don't know much about that someplace else. And we don't even know if you're taking your medicine, never mind whether it's effective or not. So there is much that is absent from our interrogation system that requires a huge sea change. That's why I said I hate to see the discussion narrowly focused on the cost of a drug, the quality of whether or not a pacemaker or a hip replacement was necessary or not necessary. We need a complete retake about how do we garner the information, how do we partner with our patients not only in clinical care but in discovery, and how do we then annotate that information to give a much more evidence-based, scientific base to medicine.
You want to get in, but I'm also interested in, besides whatever you had, the comments you want to make about Heidi's, what she said, do you feel like we are entering this data revolution, that whatever the heirs to the Fitbits and the Nike Fuel Bands are, that's going to be changing medicine?
Yeah, so let me answer the first part. In response to Heidi, I think it is not surprising at all, the data you said, that we do really well in the medical part of the intervention when people are in hospitals. We do that really well, but in the other 11 months we do crappy because, so the other thing that's different with us in Europe, in the US we spend twice as much on healthcare, 18% of GDP, and half as much on social systems and social support. It's flipped in Europe, right? They spend half as much on healthcare and twice as much on social support. And I think the dirty little secret is very little. If our goal is improving the health of populations, making people healthy and keeping them out of trouble, medical care is only a tiny part of it, and we are way over-investing in the medical care and way under-investing in the stuff that's not typically medical care. And we have a very skewed system where you get paid a ton to do stuff that's medical and not at all to do other stuff, but the other stuff may well be more effective, right? So I think we've seen over and over again, what do you do? We build practices that start from scratch and take care of vulnerable populations, and often the intervention that is the most effective has nothing to do with giving them a drug or a pacemaker. It has to do with doing something to fix their lives, and that will actually prevent the infant mortality, than anything we could do in the medical system. I think we're just investing poorly. I think we need, Denny mentioned this too, I think we need not a little change, but a big change in how we think about healthcare in this country. I think even Obamacare is tinkering around the edges, right? It's still very much a medical system. It's still very much building on top of fee-for-service. I think we need to rethink how we do this in a variety of ways. I completely agree, Denny. I think I try to manage hypertension in my office in a typical practice with 4 readings a year. It is ridiculous to think I can manage someone's hypertension with 4 readings, 1 every 3 months, when they're in an office, when they're sort of scared and they just, upset about the parking that they paid $30 for and all of that, right? It's just ridiculous, right? So yes, I think that the right way to do this, obviously, is to get a ton of data in from when people are living their normal life, And I think the problem is we don't know how to interpret that data. There is so much of it. I was talking to someone who was doing a clinical trial for musculoskeletal disease, and they've got these constant activity monitors. They're getting 1 gigabyte of data per day per patient. But this is a tremendous amount of data. And so what we need to do is figure out how do we interpret that data? How do we pick signals out of the noise? How do we actually know how to turn that into action? And so I think we're just starting that. It's very exciting, but that requires very different ways of thinking and not sort of little incremental changes.
We're going to go to questions in a minute. So if you have questions, you can stand up next to the microphones in either aisle here and ask them. I should say you will be on YouTube because we're live streaming this on YouTube, just so you know, in case you don't want to be out there or anything. But while you're thinking of questions and lining up, if you have them, I'll mention 2 quick things about this whole data thing, and maybe that's where we're moving. I'm interested in what Heidi thinks of this. One is, I have a friend who's a primary care physician, and she was telling me, like a couple, maybe months ago, said that occasionally somebody will forward her the email that they get from like Fitbit that says how many steps you went, and this is your pulse rate and everything, and she thinks, what am I supposed to do with this? I get so many emails. I don't need one more email. So that speaks to your point of you have to give it to doctors. They're already so busy. She's got kids, her own kids. She's got people in the practice, and she's got to sort of figure this out. The second, though, is that there does seem to have been some inroads by Watson from IBM, which I know has done work with Memorial Sloan Kettering, I think MD Anderson, a whole bunch of other places, in really trying to be the assistant to the doctor. So a doctor sees a certain kind of cancer, and the doctor hasn't read the thousands of articles that might be pertinent because they're too busy being a doctor. But maybe Watson knows that, for a woman with Japanese heritage who's this age and whatever, this is what the literature says.
Well, let me make 2 comments, and I'd be very interested. I suspect there are people in the audience here who have a lot to offer in this space. First of all, one has to distinguish in medicine between what we call structured data and unstructured data. Watson is absolutely sensational at structured data.
And good at Jeopardy.
But the world is probably not waiting for Watson to make a diagnosis in 2 seconds that I can make in 2 minutes. Where the real data glut exists, and where here we are sitting in the world capital of data, and where data has to be generated that can be annotated to lead to knowledge that's actionable, is largely in the unstructured. The medical records, the ability for patients to describe or annotate their own feelings, their own symptoms, daily living, what the diet looks like, what the exercise looks like. The problem with our annotation at the moment, and I spend my life now doing this in real time, is that everything, there's thousands, tens of thousands of apps for healthcare, fitness, the disease management, weight, etc. We all know them, we've all used them. And as you know, the drop-off in use is dramatic after a short period of time. The problem is they're all commodities. They're not prioritized in either the precision or the importance of the measurement, and none of them are integrated into a healthcare delivery system. So the only way we're going to move from this data glut, and I agree with Rushika, we have an enormous amount of data, to a data resource that provides proper annotation that leads to knowledge and actionable, is a fully integrated holistic system. And that's coming. And there are companies that are non-traditionalists, like the Googles and the Apples and the Microsofts. Everybody thinks they're in the healthcare business today. And quite frankly, for good reason. It's, many trillions of dollars out there. It's not going away. And if you ask the CEOs of these companies, they think that a large percentage of their profits will be in healthcare over the next 25 years. I personally think that's a good thing. I think we need all the help we can get for data annotation in real life under perturbable situations that provide the kind of evidence that we're talking about.
Yeah, but does that concern you that even more people are looking to be part of the healthcare pie? I mean, look, we already talked about how many people want to cut.
If you can cure cancer, there'll be enough ships rising for everybody. Okay.
Don't be shy about questions. I'm sure you've got great ones, so I can ask more here, but yeah. We want to hear what you have to say. Heidi, any thoughts on this idea of data and like, whether people are making informed decisions, whether doctors are making informed decisions about the healthcare they're providing, recommending?
So it's definitely not my area of expertise, but one part of this revolution is sort of thinking about just electronic medical records and sort of things of that sort. And when we look just empirically at, do those generate big productivity improvements, either declines in costs or improve in patient health outcomes or improves in quality of care measures, you don't see a lot of evidence that those are making a huge difference as they've been implemented in the past. And I think that's not surprising when you look at just the history of information technology adoption in other industries and manufacturing. So when other industries first started adopting these kinds of data-intensive information technologies, they didn't result in huge productivity improvements right away, and it took a while for them to pan out. And so it may just be that we need to wait and things are going to get better, but I think it has been somewhat frustrating that there's been this huge push for subsidies to adoption of electronic medical record system and thinking that this was going to immediately pay off in some productivity sense, and it just doesn't jump out of the data that so far that's really panned out. And so I have hopes that are uninformed, that things are going to get better, but it has been a little bit of a disappointment, I think, so far.
So it shouldn't be surprising to anyone that it hadn't improved productivity. These systems were never built to improve clinical care. They were built for documenting, coding, and billing. The way they sell themselves to physicians is you can bill higher and get more income, and therefore you can justify the cost of the system. So they are fancy billing systems. Actually, in a way, what they try to do is get the docs to structure the data, and they make the doctor's life miserable, because you take what used to be a nice unstructured note about someone and turn it into 50 different clicks and 30 different pages, which actually hurts productivity and makes one actually do more. So do we need computers in healthcare? Absolutely. It's ridiculous in 2015 not to use them. Do we need a fundamentally different system that we have now? Yes. And unfortunately, in its wisdom, our government decided to cross-subsidize this crap and pay, basically require people to use it, what's currently out there, and subsidize it. And so we get more of it, and there's almost no incentive for the current folks to actually improve their product because the government will pay for it as is.
Brave first questioner over here.
So I'm curious what you guys think about the relationship between healthcare and other industries, such as food and advertising. Because if you look at, $1 out of $5 of our GDP being spent on healthcare, most of that money is spent on chronic disease management, something that can actually be avoided by lifestyle change. So the way I look at it, the public health impact of teaching people how to move around more and eat less sugar is actually much bigger than curing cancer. So in my view, the healthcare industry has to come forward and be more of an educator as opposed to treating something that's already wrong, so to say, because that's where we get the the sick care model, basically.
So I completely agree with you. And the reason I agree with you is that we were all trained to diagnose disease and to treat disease and its progression to ultimately death. We're the only profession in the world that doesn't know its gold standard. We can't diagnose wellness and its progression to illness. And again, we've talked to many of the reasons why this is the case. Episodic symptomatic approach, our learned scholars are really based on terms of the information surrounding pathology. But we lack the information because we're not garnering it in the time frame and in the continuity frame that will be required for us to identify wellness versus disease. There is a movement, as you know, around the world now, whether it's the quantified self or patients like me or et cetera, where fundamentally understanding what wellness looks like and how do you slow the progression from wellness to disease. Many of the things you talked about, of course, require behavior change, which is the bugaboo of all physicians, I can tell you, and lifestyle change. Type 2 diabetes in the year 2015, type 2 diabetes, a world global epidemic, the major therapeutic intervention, the most successful therapeutic intervention is lifestyle change. It's better than drugs, et cetera. So absolutely, but we need to first develop the standards of what does wellness look like. And we have many more toolkits now. We thought when we cloned the human genome, there would be a magic book there to tell us that. It's a very good book, but it needs to be annotated with behavior and environment in a much more complicated way. We're going to get there, but it's still a long journey.
Denny, I just have a question for you. If, like, the president said to you tomorrow, come into my office, here's a bunch of money, here's a bunch of resources. You really think that this whole lifestyle thing should be much more part of our medical system, not just when people are sick and are have to go to the doctor. What would you do? What would you advise him to immediately do?
I would immediately come back to the point that Rushika made. This is not a medical problem. This is a cultural problem. We have to fundamentally understand that we want to understand ourselves and the quality and quantity of our life. And
Does this mean putting Fitbits on everybody?
we want partnerships to do that. I believe the physician and the healthcare system as a whole can be a legitimate partner in this, but it requires a much broader societal partnership. And it may require non-traditional partnerships with the Apples and the Googles of the world. I use that only as an example, but we need to fundamentally understand, are we willing to ask the questions about what makes us well? And then are we willing to delve into the science that can interrogate that? We've discovered a whole new organ called the microbiome, which when I was a student, and probably even when Rushika was a student, it was an artifact of evolution. You're born sterile and we enter a dirty world and you're contaminated with bacteria. By the way, you have 10 times more bacterial cells than you have human cells. Now, in that context, we now know it's a completely new organ and it affects at least 50%, if not more, of the immune system, causing inflammation that causes every disease from obesity to diabetes to cancer. Now, how are we going to begin to interrogate that? How are we going to begin to look at the lifestyle changes, the behavioral changes, and the toolkits to inform us what's right, what isn't right, et cetera? And there'll be diversity to that. So this is science. We're not talking about hocus pocus here. There's science to be had here. That's not where we're investing our scientific dollar.
Yeah, quick comment. Again, we need to be investing not in medical care. So because healthcare costs are going up, many cities and states have to cut their school budgets. So they cut the physical education out, they cut the healthy school lunches out, right? These are all connected. And I think if we take a broader view of how do we improve health and don't put health care up on this great pedestal and fund all our resources to that, then we might make more impact.
I remember maybe a year or two ago, there was a big brouhaha over the fact that the tomato sauce on pizza in schools was classified by the House of Representatives as a vegetable. And yeah, there was a whole,
I thought it was ketchup, but all right.
Ketchup probably counts too. I mean, some tomato is important. Heidi, did you want to say something real quickly?
Yeah, well, I was just going to say, sort of following up on the infant mortality results that we had talked about before, I think a lot of people think of medicine as a place where we do randomized trials. We do a drug relative to a placebo and we learn whether things are working for patients. But you can do those kinds of things for these social interventions as well. And so in the case of infant mortality, in Europe, there's a lot of things that are often termed as home nurse programs where providers come to visit people at their homes and they look at aspects that might be unsafe for the infants. And when we looked at those in randomized trials, those look like those have really big effects on reducing infant mortality rates from the kinds of causes that the US seems to have excess deaths from, so from accidents and things like that. And so, I think we just want to think of bringing a scientific approach to the social aspect of health in the same way that we do for the medical aspect of health.
Question over here.
So I'm curious, for the average patient or consumer, if they could help solve this problem, is it be a better educated patient and ask questions around cost? Is it go to a community hospital instead of the Brigham or MGH? Is it just change your lifestyle, as you were talking about before? What could, if you could tell every patient as opposed to the president, what would that be?
Yeah, it's not a single entity. As you know, I'm very proud, and I make no bones about it, of being what I believe is the best hospital in the world at Mass General Hospital. But it's a question of how do we make the cultural sea change that actually engineers unifying wellness with the spirit of inquiry. I'm a scientist. I'm a cell biologist by training. I've spent most of my lifetime doing basic research. I'm a big believer that there is much science to be done, but the patient is the harbor of the information that will help inform this. My generation of physician, whether they're at the Mass General or any place else, has done a good job of telling patients what we think we know about a problem and here's what to do about it. We have never done a good job of telling a patient what we don't know about a problem and here's how you can help us solve it. So we need fundamental commitment to partnership, not just in clinical care, but in discovery. And that partnership ultimately will lead, whether it's through new digital devices, whether it's through the digital age as a whole, whether it's through better social programs, et cetera, will lead to a much more holistic view of wellness and what intervention can do to slow progression to disease. There will be strong science in there. It will still involve genetics. It will still involve the microbiome. Behavioral science is a science. There are ways to engineer the way we think about behavior and behavior modification. I work with Sandy Petland here at the Media Lab at MIT, who runs the Human Dynamics Lab. And he has developed he wrote a beautiful book last year called Social Physics, about how we engage and learn through the internet. And it's very common to think about, how do you incentivize Denny? Well, it turns out the best way to incentivize Denny is to incentivize Rushika to incentivize Denny. Now, when I was a kid, that was called bullying. Today, it's called crowdsourcing. But the reality is, there's science there to modify behavior, to assess and to modify it. There certainly is science there to evaluate the environment, where we live, how we live in it, et cetera. We need to bring to bear all of that. And it's not a function of changing doctors or changing hospitals. I would argue the best hospitals in the world should be undertaking and will be undertaking these kinds of studies.
Let me grab another question over here.
Yeah, so you guys mentioned Obamacare just briefly. Question for all three of you or any of you. If you could pass one piece of legislation related to healthcare, what would it be and why?
Any wannabe legislators up here?
To me, it's pretty simple. I don't see how you can, if you really believe healthcare ought to be uniform, every society ought to have the same rights in it, then you need a single payer system.
I'm not sure I have a good answer to that question.
I think there are a whole lot of things. You know, I actually don't think the government solves a lot of problems. I think the thing that's going to fix healthcare is actually innovation. What has fixed almost everything else in this economy is we've innovated a way out of it. And I think what we need to do is sort of have the government's role, I think, ought to be to get out of the way and create a playing field where sort of people can innovate their way out of it. We don't know the right answer. We need a different way of delivering medical care that takes into account the social stuff. We need to do it in a way that's equitable. It's not clear that the government has to do it all, or that's the best solution, but they need to sort of create the rules. Right now, there are huge barriers of entry for new people to go into healthcare. In any other industry, if the incumbents were doing such a bad job, there would be a flood of new entrants in to try and do it better, and that would sort of kick the other guys in the behind a little bit to actually move faster. We don't see that in healthcare, right? I think it's antitrust enforcement. I think it's getting rid of some of the other sort of barriers to entry, the scope of practice laws, et cetera, and allow sort of more innovation to occur. That's what I do.
Question over here.
Hi. So I'm curious your guys' thoughts on the disease management space. I know it's kind of been mentioned a little bit, but do you see disease management organizations and disease management programs maybe being a stopgap measure as a move toward value-based care or ACOs or population health management? I know a lot of times they're offered through employee wellness programs now. They're not, I think they might, my understanding is they lean a little bit more on the wellness side than the medical side. They often can't prescribe through them or really solve medical problems, but I'm curious your thoughts on those solutions currently.
Let me just ask, or maybe I can ask somebody up here, give me a sense of what is disease management organization?
Sure. So there was a whole industry that grew up about 10-ish years ago called disease management, and they're companies that usually contract through employers, which have typically the model is a telephonic model. They look at the data on the population, they identify who are the people with, let's call it diabetes. They hire a group of nurses who are sitting in Idaho somewhere, and they call people up at night at dinner time and say, hi, by the way, do you know you have diabetes? I want to encourage you to take your meds and tell your doctor that you need to check your cholesterol, right? It's that, I'm exaggerating a bit. There's no one here from a disease management company. There is zero evidence that that's effective, by the way, right? I think, first of all, the fact that you need to have these people is an indictment of us, the doctors. Because last I checked, that should be our job, right? That if we're not managing people's diabetes, why would we need someone in Idaho to be calling them at dinner time, right? So is the concept of disease science the right thing? Absolutely. Should we be managing people's diseases? Sure. I think that having a random schmo from Idaho calling you at night is not the right way to do it. I think that we should be doing this using real relationships and real clinical data and getting more measurements that are done and teaching patients to be their own advocates and learn how to self-titrate things and teaching them how to eat. So yes, disease management is a great idea. I think how it's being done in general in the industry is sort of not effective.
Yeah, but if France is having like home nurses or specialists come to people's houses after they have a baby, not a doctor, but like a social worker type of thing, and say this is too dangerous, you got to put a gate in front of those stairs or whatever. If they're doing that, then why isn't it reasonable to have somebody call up and say, or check in with you at least and say, are you exercising? What are you eating? What are the obstacles? I mean, doctors are paid so much, you don't really want a doctor checking in with you all the time, do you? I mean, it seems like a very high cost for that.
It is. It is completely crazy for a doctor to be doing that, but I think that needs to be done in the context of a relationship. So I think the problem we have with U.S. healthcare fundamentally is we've turned it into a series of transactions. These document coding and billing. It's why you feel you can go to a doctor, you're a widget off the line. It's all transactional. Transactions have never healed anyone. The only thing that ever has healed anyone is relationship, right? And things in the concept of relationship. So if we get rid of the transaction based on relationship, so a random person calling you is one thing. A real human being from your doctor's office who walks into your home and looks at you eye to eye and who cares about you and you care about them, that is just so much more powerful, right? It's not about the transaction. It's about the relationship. And I think that's so much better done in a different context than sort of randomly on the phone through your employer. Again, as a doctor, if we aren't doing that, like what are we in business for, right? So we have in our practices, we have teams that we call health coaches. They're folks from the community, speak the language of the people they serve, 3 or 4 per doc. You meet them with my arm around them, so you sort of get that doctor magic on them, and then they come to your house, right? No, it is. And you put some magic in that by extended, and then they go to your house, and they talk to you and talk to you about your diabetes. That's very, very different, right? It may sound the same, but it's actually very different in an important way.
I think we have time for one more question. I'm going to take it here because I think this was the first person up.
Hey there. I've been fascinated by the discussion we've been having on technology and its implications for healthcare management. Rushika, I was wondering if you could give us an update on kind of what Iora is doing in terms of thinking about technologies. Is it currently incorporated into the practice? Like, does everyone get a Fitbit or a Jawbone up, or is the data too overwhelming? And then the flip side of that for what's going on the primary care level, for Denny, I'm wondering when we achieve that ultimate vision of pre-symptomatic continuous care, we catch diseases before they progress into full-fledged chronic conditions. What's your vision for what MGH will be doing and like the types of things that will be done in hospitals?
So maybe I'll start. So what we're building is what I call a new operating system for healthcare, which is a tight link between a new technology platform and then the human beings who can take the results of those technology and turn it into behavior change, because in the end, that's what you need. We don't use an electronic health record because those are cash registers. They're document coding billing, not useful. What we build is what we call a collaborative care platform, right? And the goal is to take a ton of data about the patient from everywhere, exactly as Denny mentioned. And the sort of devices, the data, it depends on who you are and what your need is. So whether it's an activity tracker, your weight, your peak flow, your blood pressures, your blood sugars. So what are the things that we should be tracking for you? Let's get that data in. Let's get your claims data. Let's figure out when you've seen the doctor. And then let's find signals in the data and then turn it into what we can change action, right? So you need to up your medicine, change your diet, et cetera. So that's sort of what we do. It's a big part of what you need. I think the right solution to healthcare, so Google Health, we're here. I think had an earlier iteration, where they would get people to sort of track their data and all that, and it sort of collapsed because they didn't really do anything. Technology by itself is not that interesting. Technology in the context of relationship and other human beings, I think that's what's really interesting to change care. Now, what will happen when we prevent all the disease? What would happen to Mass General? It won't happen. We could prevent some, but not all.
Well, we won't be closing our doors anytime soon, that I can assure you. I agree with everything you said, so I won't repeat it, but I'll highlight a few areas. First of all, the word you heard growing out of our discussion is integrated delivery systems. And that integration, I absolutely agree, depends on people, not machines. But machines, toolkits, and skill sets can enhance much of that. And we would be foolish to be living in such a technologically advanced era and not take advantage of that. We can now build sensors the size of a pinhead that can monitor things we had no clue we could even monitor before. And I won't go into any details about that, but those are on the horizon and on the near horizon. Having said that, if we really turn our attention to pre-symptomatic continuous assessment tools, then at the same time, the continuum of what a hospital is will change. Remember, today, hospitals are endgame in all phases of healthcare. To get into a place like the Mass General Hospital, you have to have 12 diseases and be dying of 4. I mean, it is just the reality of the way we care for people today. When I was an intern, and I would posit, even when Rushika was an intern, people would come in with diseases for 3-4 weeks. I used to admit patients with rheumatoid arthritis, and this is not 100 years ago, this is only 35 years ago, and we would embed their hands in paraffin for 6 weeks, and they would stay in the hospital. You got to know them, their family, their dog, etc. Relationship building was much easier then, okay? 6 weeks with one intern, you learned a lot. The reality is now you see your doctor for 10 minutes. So integration of those relationships becomes intimately important. And I would argue that while the fairy dust of the doctor and the environment does have some magic to it, we need to make that extensive, and I think technology will help make that extensive. And so a place like Mass General will be a continuum. You still need, of course, acute care. You get hit by a bus, you still want to be close to the Mass General. Elective procedures are still going to be necessary. You want to have a good hospital. But what we call medical care today will be much more expansive. It will include many of the things you heard talk about today, which are social innovation, behavioral assessment tools, as well as motivation skill sets and toolkits, as well as the science of medicine.
This has been a great discussion, and I feel like there are so many more things. I mean, I want to ask more about specialists versus primary care. There's so many more things I would like to ask you about. And I think this is an issue that touches everybody, right? It's not just doctors, because everybody's a patient and everybody's a taxpayer and all that. And I think about the healthcare system a lot, but I don't usually think about it with 2 doctors and an economist. So thank you very much. This was fantastic. Thank you for coming out, and thanks very much to the Solve Initiative at MIT and to Google for partnering on this. Really appreciate it. Thank you.
Pleasure.
It's great.
Thank you. Good to see you again. Pleasure.